So the other two abstracts that I would like to talk about would be the ones related to the Sierra trial. So these were also radioimmunotherapy conditioning-based presentations coming from the trial that has been looking at using radioactive iodine, 131 labeled CD45 antibody. So this is a beta and a gamma emitter as opposed to what I just spoke about, the astatine 211, which is an alpha emitter. So the concept, however, is the same in terms of targeting CD45, again, present on all hematopoietic cells. Most, all of the myeloid malignant cells and the lymphoid cells. So this trial specifically used Iomab, which is iodine 131 labeled CD45 antibody. And the phase 3 design included patients who had active or relapse refractory, basically high-risk AML, and they were randomized to either get Iomab-B based conditioning followed by transplant or conventional care, which would mean get some other round of chemotherapy and go to transplant if there is a remission. So, and they did allow crossover in patients who did not have a response to conventional chemotherapy. In the first study, which was presented by Dr. Nath from Banner MD Anderson, they showed that there was much less GI toxicity in the Iomab arm compared to what we traditionally use. And this is because the Iomab can deliver myeloablative doses of the radiation to the marrow and the leukemic sites, while it can spare other organs like the GI tract, which do not have CD45 expression. So that is a concept here. And in this study, they showed that patients were fairly equally distributed. The rates of sepsis were much less common in patients who went on the Iomab arm compared to the conventional care arm. There were some febrile neutropenias on both sides. There were some other infections on both sides, but the rates of sepsis and septic shock were definitely different, with only 5% in the Iomab arm and around 23% in the conventional care arm. With that in mind, Dr. Kurza presented the next abstract, which is the early results of this trial based on the initial enrollment. I think they have around 75% enrollment so far. And similarly, patients had active disease going in. Percentage marrow blasts were around 30%. Remember, these patients, you would never take them to transplant directly. You would always want to give them some chemotherapy to bring down the disease burden before you take them to transplant. So in the Iomab arm, they got Iomab and then went to transplant right away. In the conventional chemotherapy arm, they got some chemotherapy and then went on to transplant if they had a response. If not, they went back to, they could cross over to get Iomab-B. So fairly equal at baseline again. And what they showed was that 100% patients achieved neutrophil and platelet engraftment. So definitely showing the feasibility of this strategy, even though it's supposed to be less toxic, and still showing some responses in terms of in patients who have a very high risk AML, which was around 88% in the Iomab arm. So there were around half the patients who were initially randomized to the conventional care arm who did not respond and then had to be crossed over to the Iomab arm. So I think something definitely to look forward to as more data emerges in this space as well. Overall, looking at what's been presented at ASH and now at ASTCT, I think overall, this speaks to what's evolving in the field of transplant, trying to target the specific cell surface markers on leukemia cells, and combining that with the traditional conditioning chemotherapy to achieve better results in patients who have a very high-risk disease, which includes active disease at the time of transplant.